Good afternoon, everyone. Welcome to the Oregon EMS COVID-19 First Responder PPE Exposure webinar. My name is Rebecca Long. I'll be your host. We still have quite a few people logging on, but we'll get started with introductions because we have a lot to cover today. And my name is Rebecca Long, paramedic, mobile training unit coordinator for the state of Oregon. And we have Dr. David Lehrfeld with us today.
Hello, Rebecca. Thank you, everyone, for joining.
And Dr. Rebecca Pierce. Do you want to give us a little bit of an intro of who you are, Rebecca, please?
Sure. Hi, everybody. Again, my name is Rebecca Pierce. My day job is managing the Healthcare Associated Infections Program here at Oregon Health Authority. For the COVID-19 response, I'm serving as Healthcare Branch Director.
Wonderful. Thank you. And just to check, can everybody hear us okay? Perfect. Okay, just want to make sure we got the audio going. And Dr. Lehrfeld.
Thank you very much, Rebecca. And just to remind everybody, all the resources we're talking about are going to be on our Oregon Health Authority COVID-19 website, with also links to the CDC website for relevant documents. If you look under the title of Healthcare Providers, you'll find a subtab for EMS and PSATs as well, which is where we'll be posting all our relevant documents. Thank you. Just a real quick coverage of the appropriate PPE when dealing with potential COVID-19 patients. So that would include goggles or a face mask, something that there was some questions about safety goggles. What we're talking about here is something that will completely protect your mucous membranes, an N95 mask or a surgical mask, gloves, and a disposable gown. If EMS transports a patient that eventually later tests positive for COVID-19, the process for notifying EMS is that labs are required by law to report the positive tests to the Oregon Health Authority, and the Oregon Health Authority will pass those positive test results back to the local public health authority, who should do contact tracing and contact the EMS agency. Second pathway is that the hospital runs the test internally and are required by law to report the test results to the Oregon Health Authority, who will again pass it on to the local public health authority. The hospital is not required to, but it is best practice that if the hospital knows the patient was transported by EMS, to inform the EMS crews themselves. Additionally, when the Oregon Health Authority learns of any positive COVID-19 tests, we will run it against our Nemesis database to see if that patient has a record in there, and if so, we will inform the local public health authority of the EMS transport and attempt to contact the EMS agency directly to let them know of the positive result. This is covered under the Ryan White Act and local public health law. When an EMS agency is informed that they have transported a COVID-19 positive patient, they should assess the risk of the crew that transported them to see if they were wearing proper PPE for the level of exposure. We'll have a document posted on our COVID website and will be distributed this evening through the image trend system to all agencies. The document will have a risk matrix and work exclusion recommendations. These are only recommendations, they're not mandatory. But to quickly summarize, if an EMS crew is providing patient care that did not include aerosolized generating procedures, which are covered in the document, without a regular face mask, respirator, or eye protection, so we're talking covering mucous membranes, then they should be considered high risk. If they provided patient care that involved extensive contact with the patient and their immediate environment, assisting with the stretcher, removing clothes, etc., without using contact precautions such as a gown and gloves, in addition to face mask, respirator, and eye protection, they should be considered high risk. And if they provided any patient care that did include aerosolized generating procedures without full PPE, including N95, they should be considered high risk. In general, aerosolized generating procedures are considered anything with positive pressure. So that would include high flow nasal O2. If it's used, you should put a mask over the nasal cannula. Anything that involves a BBM, so straight up BBM, BBM on a supraglottic airway, BBM on a endotracheal tube. Best practices, if you're using an automatic ventilator, to make sure you have a viral filter on your ventilator. BiPAP and CPAP machines are open circuits, so there's no way to filter that air. If you do have a crew that categorizes as high risk, you can consider allowing the healthcare worker to continue work if they're asymptomatic in consultation with your occupational health program. Consider reassigning high-risk healthcare providers to non-patient care duties during the monitoring period, which would be 14 days after the high-risk contact. The healthcare provider should still undergo daily active monitoring for fevers and signs of respiratory infection, such as runny nose and cough. If a healthcare provider develops even mild symptoms consistent with COVID-19, they should cease patient care activities, don a face mask, notify their supervisor or occupational health services prior to leaving work. In the document that will be distributed this evening, this is the risk matrix. It's similar to the risk matrix for all healthcare workers, but it's specific for EMS, and that there is no low risk category for EMS due to the ambulance environment and the close contact we have with our patients. You can see that the medium risk, it recommends self-monitoring for 14 days. That is, the healthcare worker will monitor themselves for symptoms of fever or upper respiratory infection, but don't have to actively contact their occupational health supervisor unless it is your company's policy. And that high-risk patients should be excluded from work during this monitoring period with active monitoring, that is communicating with OC Health at least once a day for their symptomatology. Keep in mind, this is a rapidly evolving risk matrix. As testing becomes more widespread and as our understanding of this disease grows, this could change on a daily basis.
One thing to add for you guys, this is Rebecca. In the handout section of the webinar, you will see a PDF version of this slide deck, and you will have the handout that Dr. Lehrfield is referring to.
It's important that we take care of each other. If you do have a healthcare provider that has an exposure to a COVID-19 positive patient, and you are going to implement work exclusions, be sure to communicate in a non-punitive way why work exclusions are essential to prevent associated infections. Discuss the plan for exclusion and monitoring ahead of time with your medical director and occupational health supervisor to determine at what level of risk you will have work exclusion, whether you have active monitoring or self-monitoring. Educate on appropriate monitoring for symptoms, which would be fever and signs of upper respiratory symptoms. Stress to employees that they should not come to work while ill. These aren't just the healthcare workers that have been risk stratified for COVID-19 contact. This is any healthcare worker should not come to work if they have a fever or sign of upper respiratory infection, regardless of the disease. Keep in mind that while we have 24 COVID positive patients in Oregon right now, last week alone we had almost 800 positive flu samples, and an unknown amount of untested flu out there. We don't want to give our patients flu. We don't want to give our patients COVID. We don't want to give our patients meningitis. So if you're sick and you're a healthcare worker, just don't come to work. Develop a plan for what the healthcare worker will do if they become symptomatic. This plan should be in conjunction with OHCA Health. If you don't have OHCA Health in your organization, your local public health authority should establish a monitoring plan for you if you're a person under monitoring because you've had direct contact with a COVID-19 patient.
Okay, we're going to move into some of the registration questions, and Becca Pierce is going to answer some of those for us and read them off. I just want to thank everybody out there who, one, registered for the webinar and is attending today and posing questions. We had over 250 questions posed. We were trying to kind of triage them and go through the ones that a lot of them were kind of the same questions about PPE and exposure. So we filtered them down and we're going to try and answer as many as we can. If we didn't get to your question today, please know that we have it logged. We are looking at that stuff and we're going to try and get you info as we can in the future on FAQs, and we're just going to keep getting that information out to you guys. So, and I just, as a former medic and on the line, I just want to say thank you to everybody out there who is doing this and who is responding in healthcare. Because everybody has a lot of questions right now. And so, again, we're trying to get all that out to you. So, Becca, let me get you signed up so you can start answering some questions and unmuted. Okay, Becca?
Yeah, hi, can you hear me?
We can hear you, thank you.
Okay. So I'm gonna try and walk through these questions as efficiently as I can here. So one of the first questions I had are, what are the PPE recommendations for responders potentially at risk for severe disease, those immunocompromised, or those over the age of 65? So this is something we'd really urge you to discuss with your occupational health and supervisors to discuss medical clearance for patient care activities. In general, as David mentioned, we are recommending all responders utilize the full PPE for care of patients with respiratory illness. So, that's a respirator, N95 or higher, eye protection, gown, and gloves. General ways to protect yourself are the same ones we are always using. So using hand hygiene before and after all patient contact, cleaning and disinfecting using EPA-registered disinfectants, with known effectiveness against human coronavirus, and importantly, avoiding contact with the face. This is really a tough one, I think, for everyone, but particularly for healthcare workers as we're donning and doffing and doing all those things, just limiting that contact as much as possible. There were some general questions about how COVID-19 is spread. I think everyone is aware that this is a kind of rapidly evolving situation, and data is coming in at kind of a fever pitch right now. So we don't have all the answers, but based on what we do know about COVID-19 and other coronaviruses, spread is generally thought to occur from person to person via respiratory droplets, as well as direct contact with respiratory secretions. So generally, this is close contact, and for healthcare workers, that's generally patient care, and then having contact with infectious secretions. So it is not known right now how long COVID-19 can last on surfaces, but there is believed to be some role for contact-based transmission of COVID-19. So that being said, it is an enveloped virus and can certainly be killed by disinfectants. EPA has come out with a list of appropriate disinfectants for COVID-19 that is posted on their website, as well as in our guidance. But that, it can survive on surfaces that can play a role, but disinfecting can be effective. It's a good question. Are there any vaccines that would help decrease symptoms of the disease? So there are no vaccines currently available for coronaviruses. However, we do recommend obtaining the flu vaccine if you have not already done so. It would certainly reduce the chance of getting a syndrome of disease that could be confused with coronavirus. And it can also decrease the chance of contact with sick individuals at healthcare settings. There is a pneumococcal vaccine. It's generally recommended for those over the age of 65. So if there are individuals that meet this criteria, it could be discussed with your doctor. Do we need to wear gowns? So the current requirement is for gown use, particularly for first responders, as the contact that is currently experienced during patient care is close and prolonged. However, we realize there are shortages of gowns. So, both we and CDC have stated that they can be prioritized for aerosol generating procedures, care where you're anticipating any splashes or sprays, and high contact patient care activities. So these are things like, log rolling, and things that have that kind of prolonged direct contact. In general, if you look at our risk categorization for evaluating those with a potential exposure to COVID-19, generally not wearing a gown is considered a low risk exposure. That being said, there are those caveats where, really close patient contact has occurred and could potentially pose a higher risk. So I think use can be streamlined a bit, but it is part of the basic recommendation. What should law enforcement do? So both for us and CDC, we are using the same guidance for law enforcement that we use for EMS. CDC has, I think, done a nice job in providing some caveats, understanding that there are potential PPE shortages occurring all over the country. So the basic recommendation, again, is the use of a respirator, eye protection, gown, and gloves. But face masks are protective and are considered an acceptable alternative until a supply chain issue is restored. So respirators are first line use and should be prioritized when there are procedures that generate aerosols. But if there is a true shortage and we are in a contingency or crisis scenario, face masks do provide some protection, and I'll mention that a little bit more in a second. How do I protect high-risk individuals in my households? What about exposure risk for pregnant women? So if someone becomes ill in the household, and this really is for both exposed healthcare providers and anyone in the public, they should attempt to self-isolate as much as possible. I'm a mom of 2 little kids, and I understand that this is very, very difficult. But there are some basic steps you can take to protect your family. And that's, again, trying to kind of isolate in a closed door area, frequent use of hand hygiene. I know it sounds, kind of like a trifle at this point, but it really is an effective step against a virus like this, the same as it is for flu. And then doing some frequent disinfection of high touch surfaces, doorknobs, counters, things like that in your household. There is a list that I believe we have already distributed to this group that has a list of household cleaners, so not necessarily hospital grade disinfectants, that have been collected that can help ensure you're using the right disinfectants for the home. If you or someone in your family is confirmed to have COVID-19, part of the public health response will include working with you and your close contacts to protect and appropriately monitor for disease. In terms of pregnant women, there's not a lot of great data right now from published scientific reports. It is possible, of course, that pregnant women may experience immunologic changes that could make them more susceptible to any viral infection. But there's currently, not a lot of good evidence on this. There's also no real strong evidence that children are more susceptible to COVID-19. It does appear that they can be infected at the same rate that adults can. However, they typically show less severe symptoms, and this is generally believed to be because non-COVID-19 coronaviruses circulate in the population pretty frequently and are common causes of the cold, and our children are typically exposed to these at school and other settings, so they have some immunologic memory built up for these. Again, this is kind of rapidly evolving information. Reports are coming in every day, so we are updating our guidance as we find out more. The trigger for donning PPE. So do we need to get full PPE on for anyone in respiratory distress? So for respiratory distress, I would say yes. Community spread of COVID-19 has been identified here in Oregon, and respiratory distress would be a consistent presentation with COVID-19. I think there were some additional questions about this related to should we don PPE for every single interaction we have with patients we're picking up, and I think that is a challenge given the kind of PPE access we have right now. I think this is where work with our dispatch partners can help kind of streamline this as much as possible. I've worked primarily on the hospital and healthcare facility side of this, and one thing we are really pushing for is the adherence to our interfacility transfer communication rule, which remains in effect and includes any pathogen that would require transmission-based precautions. So facilities should be alerting you when COVID-19 is on the differential diagnosis list, and or the patient has severe respiratory symptoms that are consistent. Is machine washing okay to prevent the spread of COVID-19 and influenza? So CDC recommends standard protocols for laundry management. I would say my own 2 cents here is that uniforms should be washed as soon as possible at the end of the day, not left around the home. They should be pulled out of the washing machine as soon as possible, not being left in the washing machine wet for a prolonged period, and otherwise standard protocols there. Can PPE be used for multiple patients? So this is a great question. There are contingency and crisis standards for PPE that are posted on CDC's website. It's their optimization strategy information. This is included in quite a bit of what's posted on our website. So there are some pieces of information for, reuse strategies. So I'll just kind of break them out a little bit to give some information about what we know. So there are 2 reuse strategies that have historically been used for different pathogens. So the first is called extended use. This is generally considered the safer of the reuse strategies. And it involves wearing the same N95 respirator for repeated close contact encounters between different patients without removing the respirator between patient encounters. So again, that's not taking the respirator off between patients. This tends to be a little harder to operationalize for our EMS partners than in kind of, cohorted patient scenarios in hospitals, but it can potentially be used. And it is considered safer because there is this potential route for contact-based transmission of COVID-19. So touching contaminated surfaces and PPE could contaminate the hands, which could then be transmitted to mucous membranes through touching the face, et cetera. So if you're bringing your hand up, pulling off a contaminated mask, and then touching other things yourself, there is an increased risk of transmission there. So limited reuse is the other version of this strategy, and it refers to using the N95 respirator for multiple patient contacts, but removing it, doffing it appropriately after each encounter. And this is used for some respiratory pathogens, for TB, for example. So data on its safety for COVID-19 does not currently exist. And the concern that we have and CDC has is about this strategy is that, again, there's this potential role for contact-based transmission. So, it is possible that limited reuse of N95 respirators when caring for patients with COVID-19 might become necessary if crisis level PPE shortages occur. But caution should be used as there, again, is that risk of kind of touching a contaminated mask and then, contaminating yourself or your environment. What is appropriate eye protection? So what is out there is that the front and sides of the face should be completely covered. So generally this includes goggles or the disposable face shield. Certainly personal eyeglasses and contact lenses are not considered adequate eye protection. I know there's been a lot of question about the glasses that first responders are often using. I think the concern about these is they only offer some degree of peripheral protection, and they can often slide down the face when doing things like intubations or other kind of high-risk procedures. So I would defer to your occupational health or supervisors for an evaluation of this. You know, I do think it is really important that all of the face mucous membranes are protected, especially when you're performing those kind of in your face, you know, high contact, potentially aerosol generating procedures. The face shields are in general nice. I know there's going to be kind of short supply issues of this to consider as well, but they are a nice option because they both cover your mask and your entire face. So that's a good option. Can we disinfect N95 masks to reuse? And this is through either, you know, cleaning or use of UV lights. I am not aware of any strategies for mask disinfection that are effective. Unfortunately, the material is really not consistent with any procedures that could be used for disinfection. So I am not aware of anything like that. Does wearing basic ear loop mask help? Absolutely. So this was mentioned before, and I'll mention again, but I think as many of you have seen, hospital and clinic guidance was updated to allow for standard contact and droplet precautions with eye protection, as our best evidence to date suggests that the virus is spread through droplets and direct contact with respiratory secretions. However, N95 masks or higher protection are recommended for aerosol generating procedures. So our approach was that given the confines of ambulance-based care and the propensity for aerosol generating procedures, the recommendation remains standard contact and airborne precautions with eye protection for first responders. So in general, face masks generally protect the wearer from splashes and sprays. And this is not a trivial amount of protection. A major mode of transmission of these viruses is through these droplets. Respirators offer filtered air, which confers an additional protection. So it is, again, recommended for those procedures that generate aerosols. So there was a question about how small the viral particles are and how N95 masks may not confer enough protection for this. So, you know, generally with respiratory viruses, COVID-19, influenza, it's not necessarily the viral particle itself that is the infectious agent. It's the droplets that carry them from the patient and, you know, within 6 feet of where they're potentially coughing and sneezing. So for this reason, regular masks confer protection because they're protecting against those kind of sprays and droplets, and then separately respirators provide some filtering-based protection for droplets of that size. Testing for first responders. Can testing be offered to all EMS providers, even those that are asymptomatic? So testing is generally not routinely provided to asymptomatic individuals, as a negative test does not preclude you from getting symptoms a day or two later. So, you know, if you test negative and then you become symptomatic, you'd need another test to rule you out for COVID-19. So it's not a super efficient approach. Each time you need testing, you'd have to, you know, come into an environment where you could safely have a test assessment collected, increasing contact with the healthcare system and things that itself could be potentially risky. And just to note here, the incubation period is 2 to 14 days, so there's quite a range there. In general, though, exposed healthcare providers are a priority for testing. I will say that testing remains limited at our state lab, but they are working as hard as they can to meet the expanding need. Testing approvals should be obtained, and the related instructions to collect specimens from a call to the local public health authority. We have staff here at OHA answering phones 24/7, as are our local health partners. Does footwear need to be worn? This is not currently part of the PPE recommendations. They can, of course, be worn. There are reasonable justifications for their use, but as always, they should be removed between patients, and it does not replace the need for a thorough disinfection after patients disembark. I live in an area with confirmed COVID-19. How can I allay fears and concerns in my community? This is a great question and something we are working on here as well. You know, what I typically relay when I'm going out to facilities that are working with COVID-19 patients is that, you know, this is new and it's emerging. And of course, there's going to be concern and public health response, but this is a respiratory virus. We have strategies to combat this. We just need to utilize them. So using basic things like disinfecting your house, washing your hands, not touching your face, avoiding shaking hands with people, using social distancing, these can be incredibly effective strategies to reduce community-based transmission. So I think reinforcing the tools we have is really key. How to don and doff PPE appropriately. So, you know, there are some minor variations of this process for different settings and according to different agencies, but we generally use the CDC guidance. So for donning, it is typically the, sorry, lost my page here. It is typically a gown first, placing your mask or respirator, your goggles or face shield, and then your gloves. For doffing, you're generally pulling off gloves first, using safety procedures to pull the outside of the glove with your gloved hand, and then using your hands to pull the inside of your glove and turn it inside out to remove. Then removing your goggles or face shield. One really important thing about this is, you know, the outside, you have to think of the outside of your goggles or face shield as contaminated. So do not pull from the face. You want to pull from the back of your goggles or face shield, pulling it off without touching your face to the front of those protective devices. Remove the gown next. Again, considering the gown front and sleeves to be contaminated. So pulling from the back and turning inside out to dispose. And then removing your mask or respirator. So again, the front of the mask or respirator is considered contaminated. You want to pull from the back and remove without touching your face or kind of splashing in any direction, and then discard appropriately. And just a
Rebecca?
reminder, and I know it's, yeah.
This is David. I just wanted to add that during the MERS outbreak, they found that using an alcohol-based solution on your gloves before you initiate the doffing process significantly reduced the transmission for healthcare workers.
Yeah, thanks, David. That's a really good point. And what we've been doing when we've been doing kind of donning and doffing instructions for sites is if you're doing any step of this and you're concerned that you have contaminated yourself, which happens frequently, taking your gloves off or especially taking the gown off, there is absolutely nothing wrong with using alcohol-based hand sanitizer between the steps. It's just an additional protective mechanism and generally a good idea if you have any concern. But at minimum, using hand sanitizer before and after donning and doffing PPE is necessary. All right, how to appropriately disinfect. So I'm very happy to say that the EPA has released a list of hospital grade disinfectants that can be used that are effective against coronaviruses. Again, it's an enveloped virus. It's not particularly hardy in the environment, but it can persist for some duration of time. So disinfection is really important. And I think it's really nice to have a list of potential products that we know can be effective. And that is posted on the EPA website. And it's also, we have it linked on our website as well. That is all the questions I have for now. I'm going to pass things back to our other Rebecca here.
Thanks, Becca. David, do you want to try and address some of the other questions on the list that you had available?
so many were covered so quickly, I'm not sure. I wasn't able to keep track of exactly which ones weren't covered. Let me scroll through. There's a question, are first responders required to get specific vaccines for this? If exposed, will the cost of treatment be covered? So there is no vaccine for COVID-19 right now. If one becomes available, health insurance will pay for it without copay. Health insurance also will pay for COVID-19 testing without copay. I just wanted to add there are many that up until now, the state lab was the only one doing the testing, processing about, maxing out at about 80 samples a day. The University of Washington, LabCorp, Quest, and Providence will all begin testing as early as next week. So the availability of the test and the time to get tested will shorten. The recommendations for who gets tested may change by next week as well, or the week after that. Somebody asked, are PPE recommendations the same for immunocompromised patients? So yes, PPE recommendations are the same, and I believe somebody asked for pregnant patients and for patients over 60. So the PPE recommendations apply to all healthcare workers. I'm not aware of any special populations within those. Rebecca, do you have any additional information on that?
No, yeah, same precautions required for all groups.
There's also a question on after testing, how much time is expected to pass before notification? So let me ask that a different way. If you bring in a patient that is later suspected, many of our patients don't look that sick when we brought them in. They got sick later, and thus the test was ordered. So it was a couple of days before the test was ordered and a couple of more days before the test result came back. And then it might take the local public health authority a day to track the crew down. So it could be several days after your patient contact, even up to a week before you informed. I just want to add as a caveat, you know, COVID-19 or not, anytime you get sick, you should report it and self-quarantine at home until your symptoms resolve. There's a question, are there legal ramifications to withholding or limiting care to known COVID-19 patients? I'd say that any question that begins with, are there legal ramifications? The answer is always yes. But there are the Oregon Crisis Care Guidelines that describe alternate standards of care. We are not near that point yet. They are posted on our website, and there's specific instructions and considerations for PSAPs and EMS agencies in the Oregon Crisis Care Guidelines. There's a question of law enforcement staff wearing N95s assisting the public. If they have that capability and they're working with patients that are aerosolizing, I would undergo the same precautions that healthcare workers do. That being said, this is a disease that's spread by droplets, and so contact precautions for law enforcement are most important. So I would say gloves are probably the most important part of PPE for law enforcement in their everyday work. There was a question about HIPAA and relating the COVID test results for patients. Is that covered by Ryan White? It is covered by Ryan White and public health outbreak law. And EMS crews have been being informed of their contact by their local public health authorities and by the OHA. Does EMS already have protocols in place for the notification of exposure to other illnesses? I don't know the protocols and procedures for all our 140 ambulance companies, but I would think you would have procedures in place for an all hazards plan for infectious disease, whether it be measles, the flu, meningitis. We don't want to give our patients or each other any of these diseases. So if you don't have an all hazards plan for infectious disease, you should have one. How can small rural departments who can't afford require PPE? Our suggested hierarchy is to reach out to mutual aid to your larger sister agencies. If they can't help you, reach out to the healthcare systems you work with, which usually have more purchasing power and larger stashes of PPE. And if none of that works, you can request PPE through your county OEM. They will put in ORS requests, and we are literally processing hundreds of requests for PPE per day. How long after exposure does it take for the exposed to be able to get others sick? I think, Rebecca, you answered that anywhere between 2 and 14 days. Is that correct?
That's right. The incubation period is 2 to 14 days. So the time between when someone could be exposed and then become symptomatic is 2 to 14 days.
There's a question. If we are transporting a person under investigation with symptoms of COVID-19, and so just to clarify, a person under investigation is somebody that has a risk, such as travel to a foreign country or known contact with a COVID positive patient, and then they develop symptoms of the disease, that makes you a person under investigation. Does that make the transporting crew who's transporting that person under investigation persons under monitoring? I do not believe so. I believe the person you are transporting has to be a known positive. Rebecca, could you weigh in on that?
Yeah, that's right. Generally, exposures are evaluated according to contact with a confirmed COVID-19 case, and part of that is because there are still many other respiratory viruses circulating around right now, adenoviruses, rhinoviruses, influenza. So generally action steps are taken in terms of furlough and things like that when we have a confirmed case. That being said, there are some things to consider if testing is expected to take over 3 days. Just considering the incubation period of COVID-19, if testing is expected to take a prolonged amount of time, there are some provisional steps that any facility or company can take to start thinking about potential exposures and work exclusion if you have a person under investigation. So a good first step during that phase while you're awaiting results is to do a risk assessment and think about the categories of risk that David went through, identify any potential high-risk providers, start educating on the need to symptom watch and actively monitor, and things like that. So that's the one caveat, but in general, we work after we confirm a COVID-19 case to address the potential exposures in healthcare setting.
I can throw in a couple questions.
Okay, Rebecca's got a couple of questions for us that have been coming in over the webinar.
Yeah, Becca, I'm just kind of trying to triage some questions. I think there's some good ones coming in over the webinar too that we can try and add. Got a couple questions about, is there any guidance or for or against getting a pneumonia shot that will help protect people, because it sounds like that's what a lot of people are succumbing to when they pass away from the virus. Is the current pneumococcal pneumonia shot effective on this?
So I don't think there's any evidence that people are falling ill due to pneumococcal bacterial infection secondary to coronavirus infection. It's a viral type pneumonia that's occurring for people. So not to say that getting the pneumococcal vaccine, if it's recommended by CDC, is not a completely worthwhile endeavor, but it likely will not prevent severe coronavirus disease. I think that the advocacy for vaccines around this issue is more related to, it prevents illness that, again, could be confused with coronavirus and would prevent healthcare exposures where there are potentially sick individuals.
Great, thank you. Do you know if the testing that's coming out in the next couple of days with the multiple labs, will that show people having a possible titer if they've been exposed, maybe and didn't know they were sick, but have antibodies to COVID-19?
That's a great question. Most of the tests, as I understand it, are still PCR-based tests. Speaking a little bit with a bias to what we're doing here at our state lab, there are serology tests being developed, and it does appear that people have a IgG and IgM response that are somewhat predictable, but as I understand it, the antibody tests are still under development.
Great, thank you. Do you think docked PPE is a biohazard?
So are you speaking to
sorry,
waste?
go ahead, Dana.
Yeah, the waste of a possible, presumptive positive patient. Does that need to go in a biohazard, or can that just be thrown away?
David, you want me to take this one?
Yeah, please go ahead. I was just clarifying.
Okay. So standard procedures for disposal of COVID-associated waste. So if it's not soaked through or dripping, it is not generally put in a red biohazard bag. It's considered general waste.
Okay, great, thanks. And forgive me if you spoke about this earlier, Becca. Any special procedures other than what we've already talked about with PPE when handling deceased patients who could be possible COVID-19 patients?
Yeah, there are some recommendations, and CDC has posted them on their website. They generally follow the same kind of recommendations we give for standard COVID-19 response. I think the exception is when there are things like autopsies being performed, and there are some autopsy-related procedures that can generate aerosols that need special considerations. But I'd encourage everyone to go and see the CDC recommendations for that. But there are not a lot of surprises there, pretty consistent with what we're already recommending for care of patients.
Thank you. I'm still kind of triaging them if you have one to talk to, Dr. Lippo.
Let me see if there's any.
I have one that I realized I missed.
Go ahead.
Sorry to whoever asked this very good question. So what information do we give the public about why we are using PPE and they are not? So this is a really good question, and it's come up a lot. And then I think the big issue is that effective use of personal protective equipment requires medical clearance and fit testing when it comes to N95 masks, and general training. I think, as we all know, donning and doffing is not an entirely simple procedure and requires practice, intervention, and kind of monitored training. So the truth of the matter is it's generally not effective when used by the public who are not trained to do so. That being said, there are exceptions. So if patients are the general public is visiting a patient with COVID-19 or suspect COVID-19, they are generally trained by the hospital staff or any other kind of providers to use it appropriately. So there are situations where the general public would use PPE, but the use for routine practices and walking around the public is not recommended. And mask use in particular has been kind of a hot button issue on this. And again, the issue is largely that, the general public, when they don masks, they're wearing it for long periods of time, taking it on and off, and that process can actually be a bit counterproductive as it can introduce pathogens to the face area. So that is really the primary issue, differentiating healthcare providers from the general public. And there is, of course, the other issue of we desperately need to conserve our PPE for use by first responders and healthcare providers who are providing care to sick patients.
Great, thanks, Becca. I think we spoke about this in the webinar last week, but it's good to cover it again. I just lost it.
I have a question here. It says, what should we say to people who are showing signs and symptoms but have not yet been tested? So again, I just remind everybody that there's lots of things that cause fever, runny nose, shortness of breath, and cough. We've have literally hundreds and hundreds of positive flus per week, plus normal colds and everything else out there. So the current recommendations are, if you're not sick enough to need medical care, this is the general public, that they quarantine themselves at home till they get better. The recommendations for testing currently, and of course these may change, are again, symptoms plus risk and exposures. That's travel to countries of known endemics or contact with a known COVID positive patient. Those are the ones we're recommending for testing right now. If you're sick enough to need hospitalization, no matter what your infection is, then those are the patients we need to go to the hospital.
Thank you. Yeah, the question I was going to ask was if EMS responds to a call, and Becca or Dr. Learfield, you can answer this. If EMS responds to a call and the patients are pretty stable, what is the suggestion for letting them stay at home and not actually be transported to the ER?
So at this point, if the patient is requesting transfer, and unless you have local protocols from your local public health or medical director that say otherwise, it's very high risk to not transport patients. At this point, we would recommend that those patients stay at home and self-quarantine and call their doctor from home and get home treatment. But if they request transport to the hospital and you don't have instructions otherwise, then it would be current practice to still transport them. Dr. Pierce, did you have additional recommendations on that?
No, I think you covered it.
Becca, how long after a patient quits being symptomatic are they contagious?
Yeah, we do not have definitive data on this. There are some challenges to estimating this. So there's a pretty variable duration of illness, a week to several weeks. And beyond that, there is the potential for some shedding after symptoms have resolved. And it is unclear what the role of that shedding plays in transmission. We don't know if this is live virus or not being shed. There have been some anecdotal reports of, the virus particles being identified by PCR for a period after convalescence. So we do not have good data on that. Generally, our stance is that individuals, just like with any respiratory virus, when symptomatic, are most contagious. So just from a pure biologic plausibility point of view, if someone is sneezing and coughing and having a lot of nasal secretions that they're contaminating the environment with, the risk of transmission is much, much higher. So generally, recommendations around protection against exposure are confined to those periods from the beginning of the symptomatic clinical presentation to 3 days post resolution of fever and any respiratory symptoms. That's an estimate, but that's largely the guidance we are working with right now, based on the best information we have.
So there's a question: where do first responders sign up to help with triage and assessment of stand-up clinics? So if you wanted to be if you're a licensed healthcare worker and you want to volunteer for this or any other emergency, you would go to our website, our SERVOR website. That's SERV-OR. That's our Medical Reserve Corps. And you can sign up and get pre-credentialed there and select whether you want to deploy at the county, state, or national level. Okay, Rebecca, how are we doing on time?
We have a couple minutes left.
I'm seeing lots of questions here on what we do if we're running out of PPE. Again, project ahead of time. It takes a little time to get resource requests turned around, but again, we're asking that you look internally to just-in-time resupply, look for mutual aid from your partner agencies, look for your healthcare systems, And if all those fail, then you can contact your county Office of Emergency Management. If you contact your local public health department, they will probably refer you to OEM. And so all resource requests, whether it's for bulldozers or N95 masks, go through your county OEM, where state OEM will refer them to the proper emergency support function. There was a question about what do we do with calls for sick people where we don't know the level of risk. And let me just rephrase that. So we've had 24 positive cases so far. We've had multiple healthcare worker EMS exposures. None of them have become sick yet, but when you start looking at how they got exposed, it was because of, let me put it this way, because of a narrow differential or because of a presentation that didn't mimic that of upper respiratory illness. So we had fever with known diabetic foot. It was assumed the fever was from the foot infection. We've had fever that was assumed to be from a urinary tract infection that turned out not to be. We've had a respiratory distress that was presumed to be heart failure and fluid overload that turned out not to be. So a couple of suggestions on that: keep your differential broad. When assessing patients with limited information, a best practice would be to limit the amount of healthcare workers exposed. So if you're going into a situation where it sounds like there may be some sort of infection, one strategy would be to get the initial healthcare worker in full PPE, send them in to assess the situation, and then come back out and decide the level of protection for the rest of the crew. The level of protection for the first provider that goes in to assess would really depend on, you know, how intimate you need to be for your assessment. If you're assessing from across the room from 6 feet away, that's a different level of protection from if you're putting a stethoscope on a patient.
Becca, another good question. Have any patients presented without a fever but have been positive?
Yeah, that is a very good question. So I'm speaking more generally to evidence we have from China and many other places right now. Fever does typically occur during the course of illness. So somewhere between 83 and 98% of cases have a fever at some point. However, only about 40% presented with fever initially. And this is also certainly of immunocompromised individuals or those with certain other medical conditions that may be less likely to present with a fever. So that's generally why we stay pretty broad on the symptom list. So, and say things like fever or respiratory symptoms, making sure that we're being encompassing to those because it is not always present at time of symptom onset.
There's a question: how will we be notified of cases in our area and possible exposure risks? So I'm reading that this is cases in the area and possible exposure risks. So if you provide health care to a known COVID positive patient, we've sort of covered that. Your local public health department will notify you. If there are healthcare facilities within your ASA with known positive patients, you will be notified as well. But general notification of potential risks and any case in your area, that is not really covered. This is healthcare provider to healthcare provider information.
David, this is Becca. One thing I would add on that is that, we do publish case counts and numbers of individuals being tested on our website. And I believe this information is provided by county. So it's not direct patient to patient or provider to provider notification, but it is as real time as we can get it information about regional issues.
Right. At the county level is the smallest subset of that.
Yeah.
Correct? Yeah. Thank you.
Becca, how long does it take to process the COVID-19 test right now?
So it can vary, and again, this is kind of rapidly changing as more demand is coming in, but we are trying to test turned around in 2 days at this point.
Great, thank you. And maybe one last question here. After someone has contracted COVID-19 and recovered, are they able to contract it again, or is there immunity? Do we know about that and the mutation of this virus yet?
So there's some initial evidence coming out on this. It is not definitive, but we are seeing IgM and IgG antibody response, which indicates some degree of protection and immunologic memory. It's unclear how that what the time frame is on that. What the assumption is at this point is that it confers protection for at least several months. So in theory, getting you to next year, much like we see with influenza and other respiratory viruses. So this information is coming out within the last week, so it is brand new, and we'll kind of update our information as we know more.
Wonderful. Thank you. I want to thank you, Becca, and I want to thank you, Dr. Lehrfield, and thank you, everybody on the call. Again, we do have your questions that we weren't able to get to today, so we will try to get to those and answer them in some capacity, even if we don't reach out to you directly. Thank you, everybody, for joining in on the webinar today. And again, please visit our website for the latest information as we update it. We will get it out to you as fast as we can. Thanks, Becca. Thanks, Dr. Lehrfield.
Thank you, Dr. Pierce. Thank you, Rebecca.